like to begin answering questions that you've submitted. As a reminder, you can submit your questions through the live Q&A box at the bottom of your screen. Our first question is for Professor Weber. Professor Weber, the first two questions are for you regarding UVC disinfection. The first question is, you mentioned UVC disinfection in your presentation. We currently use a hydrogen peroxide system, and at times we get bubbles on the tip transducer. The probe is often replaced. Does UVC have an impact on the probe material, as we are often told that it does?
So that has been studied, and the answer is the UVC does not affect the probe material. And it's been studied both in probes, and it's been studied for room disinfection without any harmful effects on a variety of materials such as plastics, glass, stainless steel, laminates, and other surfaces.
Thank you. The next question is also regarding UVC disinfection. Can you shed light on what was used as a cleaning agent? There's been discussion in the community as to whether the chemistry used is recognised as a cleaning agent or LLD.
So the goal of cleaning is not disinfection. The goal of cleaning is the physical removal of dirt, grime, which also removes bacteria, as well as if you have gel on the probe to aid in the ultrasound, you want to physically remove that before disinfection. So before you do high-level disinfection, it is not necessary to use a low-level disinfectant. The goal is just physical removal, and that removes somewhere between 2 and 4 logs of material. That's true both for probes and for surgical instruments as well. And you would follow whatever the manufacturer has recommended for that cleaning material.
Thank you. The next question is for Dr. Castello. We often get infections from peripheral intravenous catheters. We have a peripheral IV insertion bundle, which we use as a checklist, but ultrasound is not included in the checklist. What does your ICU department do?
Well, that's a very good example of how point-of-care ultrasound is not even considered with respect to infection control, and how we spend a fortune. If you think about the money that are spent on 3-chlorhexidine washes, full body drapes, well over $100 is spent on infection control per central line, and people are whinging over $2-3 for high-level disinfection. We need to get over this culture of it being acceptable not to consider point of care as a infection control hazard. The way we do it is we have high-level disinfection with ultraviolet C for the probe, but it's not the be-all and end-all. You have to also have chemical disinfection of the machine. Our protocol for how we deal with it is basically every probe gets a high-level disinfection immediately before it is used using ultraviolet C. There's a couple of reasons for that. You've got to go and get the machine from its bay. It's right beside the thing. It's already been cleaned, not just with a detergent, but also with a low-level clean immediately after use. But the key step that we do is we do a high-level disinfection of the probe just before use. And you can maintain that again with a cover if you want to maintain an absolute trail of high-level disinfection. The other advantage is that the machine records the time and the probe that's been cleaned, and then that, of course, can be matched up with the time on the ultrasound on the recorded images. So we do have a documentation trail, but really the way we deal with it is the cleaning, the most important clean is done immediately before use. Or sorry, the most important disinfection is the one immediately before use. Obviously, after the probe has been used and the machine has been used, it is actually given a clean and a low-level disinfection as standard. But you are relying on the person then doing the high-level disinfection immediately before use. That's the way we do it. For better or worse, there's no easy way, to absolutely maintain a trail.
Dr. Castello, the next question is also for you. Regarding insertion of central lines in ICU, usually the same probe is used on the critical field, is used for the initial landmark ultrasound. The common argument for not performing HLD of probe after the landmark US and immediately prior to use on the critical field is practicality and time. Is LLD an alternative, or should we be insisting on HLD at this point?
Well, I think, as I've said, that LLD is an alternative and is considered a reasonable alternative by the asthma safety guidelines. But the advantages, the cost and the practicality issues are much smaller in reality than what people perceive. We're talking perhaps $1 extra cost, perhaps 30 seconds to a minute extra clean, for a loss of the benefit of high-level disinfection. So our situation is things are not as chaotic in intensive care as in an emergency department. I would agree with that. But
I'll just stop you there, Dr. Castello. We seem to be having an audio problem. Possibly your mobile phone could be near you, or you might have knocked it out of its plug. Sorry, have you finished your answer?
Yeah, I finished what I need to say.